Sau đây thì tôi xin giới thiệu, có thể nói rằng là một speaker rất là lớn của Singapore về một cái chủ đề vô cùng hot ở trên thế giới, đấy là vấn đề can thiệp vào đĩa đệm trong điều trị giảm đau cột sống.
Thank you for your kind introduction, Dr. Zhang. It's a pleasure for me to be here to share with everyone a topic that's very close to my heart, annuloplasty for low back pain. It's a topic to be delivered in 1 hour, but I'll try to do this in 20 minutes. So back pain itself is very common, right? And discogenic back pain is a major cause of non-specific low back pain as well as radiculopathy too. Up to 40% of back pain has got some form of internal disc disruption, whereby when we define internal disc disruption, we talk about a concordant pain provocation at discography. Once the pain is present, this pain can persist for up to 80% of the patients. We know that discogenic back pain or degenerative disc disorder, they are responsible for a significant proportion of lumbago or lumbar discogenic pain. We define this degenerative disc disorder as a disorder of the nucleus pulposus, whereby there's rupture of the annular fibrosis, as well as the injury of the cartilage end plate. There's also a lot of free nerve ending, whereby there's ramification of all these pain fibers that actually grows into the posterior annular space and forming granulation tissues. And there is a neovascularization of the posterior annular space of the disc itself. So once that happens, together with a lot of other growth factors, macrophages, etc., and there's a lot of all this repair and degeneration that's ongoing in the disc, this will result in what we call disc disruption or discogenic back pain. This is a diagram that is more clear to be able to describe what I just said. There is a loss of nuclear hydrostatic pressure right at the top, and then that results in delamination, fissuring, microfractures. But more importantly is the second part of it, whereby there is sensitization of nociceptors. So after all those changes, physiological changes, we will see all these neovascularizations and the sensitization of the nociceptors, promoting all the prostaglandins as well as phospholipids, A2, interleukin 1s, and what we call the repetitive stimulation of the dorsal root ganglion. So once all that happened, even in itself, without a mechanical product, you can have a discogenic back pain. So on one hand, it is just a physiological change with a lot of sensitization going on. The other part of it is whereby the disc itself starts to have a mechanical outcome, whereby the disc itself starts to migrate. There is annular weakening at this part. Once the annulus is weakened, there is nuclear migration, and then there is bulging. And this part of it will start to form a mechanical as well as a chemical effect onto the nerve. When is it a pure discogenic pain, and when does it become a mechanical disc problem whereby there is a nerve irritation or nerve compression? That is actually very difficult to be able to delineate and to separate. The assessment of discogenic back pain is that, number one, a lot of the patients will complain of an axial low back pain, plus minus radiculopathy. 80% of the time is mainly axial, 20% may have what we call radiculopathy component to that. There is a significant amount of intolerance to sitting. After 30 minutes of sitting, patients will find it painful. They have to change their position. They have to stand, they have to shift, they have to move. Back pain itself that is not triggered or not elicited by pressure on the muscles, on the paraspinous muscles. Back pain that does not respond to conservative treatment, may it be pharmacotherapy, physical therapy, physiotherapy, up to 6 weeks. There is no previous back surgery. This part about herniation, that is difficult, as I said. When does it become a purely mechanical compression? When is it just a discogenic itself? Definitely no spinal stenosis, no spondylolisthesis, listhesis, pain itself that is not due to infection or bleeding, whereby there is a suggestion of an annular tear within the disc itself, and most importantly, provocation, a positive provocation test on discogram. So if you see down here, whereby the disc itself is not herniated, you just get a black disc itself at the L3. So we may say that this is a disc bulge, and the pain the patient is suffering from, the back pain, may be coming from a discogenic cause. And when the disc itself starts to herniate, and you could see that at L4 and L5, whereby there is herniation, there may be a mechanical or chemical irritation to the surrounding nerve. Definitely when we start seeing bigger herniation and migration or sequestration of the disc, whereby it goes beyond what we call the 2AB or the 2A, all these very large herniations will not be suitable to be applied with annuloplasty. I'll come to annuloplasty very soon. So that sets the stage to define ourselves, to limit ourselves, to use annuloplasty to treat back pain that is coming from a discogenic source. There are people who will promote or advocate that you need to do a discogram to define this as a discogenic pain. I practice in a private hospital, so my patients do not want to come in a few times. They only want to come in one time. So all in one sitting, I sometimes do not necessarily do a discogram. A positive, but just for academic purposes, a positive provocation discography is supposed to be the gold standard, whereby you are able to elicit, is positive, whereby you are able to elicit a pain provocation. Patient will tell you that this is the pain, when we inject a 15 to 50 pressure into the disc, up to 60 centimeter of water. Patients will be blinded to the levels of the injections of where we want to place it, and the pain should subside after local anesthetic injection. For the treatment of so-called discogenic back pain, there are a whole variety of things out there. Annuloplasty is one of them, but I'll just kind of walk through with everyone. Number one, on one end, conservative. So all axial back pain, conservative treatment, up to 6 weeks. You can do physio, you can do painkillers, you can do pharmacotherapy, you can do multidisciplinary pain treatment. On the other part, surgeons will want to say that they will want to fuse the spine, they will want to do intervertebral fusion of the spine. In between, you may even have discs such as this FX, whereby you can do a bipolar radiofrequency ablation, or you can even do an endoscopic disc decompression using annuloplasty and nucleoplasty. Epidural has been tried for discogenic back pain. The results hasn't been very good, and NNT, the numbers needed to treat, is actually very poor. People have tried injecting various types of therapies, whether they put like a methylene blue, ozone, all kinds of different biological preparations into the disc itself to try to treat the discogenic pain, meeting with a kind of not very consistent kind of results. I propose whereby using thermal annular procedure, radiofrequency, the heat generated from the radiofrequency will be able to ablate just now the posterior part of the disc itself to be able to so-called eradicate and take away the pain generator. What are the principles of this annuloplasty? Is that firstly, the painful granulation tissues can be eradicated. Whether you want to do it manually using, like I do there are various versions of annuloplasty. So on one extreme end, it is just the radio frequency. On the other end, it can be an endoscopic approach whereby I can do a mechanical removal of the painful granular tissue. On the radio frequency part of it, I can do thermal destruction using the radio frequency. You can go all the way up to 60 degrees. At 45, you will start to have thermal destruction of the pain generator. There will be also degeneration and denaturation and shrinkage of the annular fibers, causing contraction. And this contraction gives a suggestion that there is a shrinkage of the annulus itself, so thereby reducing a possibility of a volume reduction even in certain disc herniated state that is not a pure discogenic pain. Annuloplasty has been around for a long time. This is not something new. It's just that in different hands, annuloplasty have different results. It has been promoted in 2000 by Sol and Sol, and it's been promoted further by Nick Bogdog from Australia, whereby in his hands, he applied an IDAT, intradiscal electrothermal ablation. He can able to achieve reproducible results, and he has published those data. However, while in 2012, it has shown that IDAT is a form of treatment to be able to help with discogenic pain. There's fair evidence for that, but not everyone is able to achieve the same kind of results. So just now I was mentioning about mechanically decompressing, apart from just burning away the painful nociceptors, burning away the painful pain generators. So there is a volume reduction, and that is something that we can use to help with patients with mild to moderate disc herniation. So for IDAT itself, the principle is that they can actually apply a needle from a contralateral side of the disc and float the entire catheter to the posterior annulus, whereby the painful so-called pain generators are. It's not easy to float the entire catheter around, so in some cases it can be successful, in others it can be very difficult. Instead of floating the entire catheter around to the contralateral side, there is another way of doing it whereby they have a flex throat needle. This is on the ipsilateral side of the pain generator. So if you notice, there is actually a J hook around on this needle, on the introducer, that allows the so-called probe to slide into the ipsilateral side of the pain generator. And it is much easier to steer as compared to trying to turn the IDAT, which have to float all the way to the other side. Position in a prone state, I do it under fluoroscopic guidance. I don't do under CT's guidance. So I find my sweet spot into a tunneled vision. More importantly is that we need to be aware to place the needle in the Cambian's triangle. Where is the Cambian's triangle? The Cambian's triangle is bounded by the exiting nerve root, A, the lateral margin of the transverse nerve, which is also the SAP, superior articulating process, as well as the upper end plate of the lower vertebral. So that is the Cambian's triangle. If you see the green part, that's where we want to place the needle, whereby the flex throat needle at the ipsilateral on the same side of the pain. Just now, as I was mentioning, if we angle it too shallow, you will have a problem. You will be skirting and you won't be in the disc. You do not feel that you're in the disc, and the needle, your introducer might be in the disc, but your probe might actually slide out, and you will be in the epidural space, and you can damage the nerve root when you do your radiofrequency ablation. If you put it too steep in, you will actually run into the problem. Rather than treating the posterior annulus, you'll be treating the center, the nucleus of the disc, which is not what we want to do. So this is where we want to place the needle. Whether we do it as a discogram or an annuloplasty, they are about the same position. So I thought I will be able to, I hope, yes. So I place the needle in. the introducer and I will slide the probe out right through to be in the posterior space. How do I know I'm in the posterior space? The lateral view is very important. You could see that the hole of the needle is just at the posterior space of the disc itself. And you could actually see the hole as if it's a tunnel vision. And when you slide the probe out, it actually follows the curve of the disc and it goes behind posteriorly. Once you are in position, we apply a step ablation. There are two versions of it. Some people will advocate to do a standard ablation whereby it's almost like a radiofrequency ablation of any of the nerves. I would prefer a step ablation whereby I slowly build up the temperature from 50 degrees upwards all the way to 70 or 90. Why 70, why 90? Depending on how confident I am, I'm not near the dorsal root ganglion, where I'm not near the nerves, I'll go all the way to 90. If I find that I'm too near the nerve during my motor stimulation of the so-called the annulus itself, if I find that at 1 volt there is a motor response, then I may want to scale down my maximum temperature to be achieved at about 70 degrees rather than 90. So we will start from 5 degrees all the way up to 70 degrees or 90 degrees every 30 seconds. And once the energy or the temperature is reached, the radio frequency will be cut off. And that's the problem about the standard ablation, whereby it ramps up the temperature too fast and it doesn't have a so-called built-up kind of a threshold. This is some of my own data for the last 5 years. 128 patients, majority of them, up to 57% of them females. A lot of them in this age group of about 40 to 60 years old. They are having back pain. They come in with a pain score of 8 out of 10. And then after treatment with annuloplasty, immediately on day 1, the pain will drop to 3 out of 10. At the end of 1 month, it will be maintaining at about 2 out of 10. And their functional status, they actually improve functionally up to 70%, and they have a satisfaction score of 4 out of 5. Are there some problems that are related to annuloplasty? Yes, there are. Be careful of thermal injury because we are applying a lot of so-called heat to that area. So if we burn that area and your probe is not in the right place, your probe is hitting at one of the posterior, whether at the end plate of the vertebral body or the dorsal root ganglion, you're going to get a lot of thermal injury in those areas. You also can get discitis. It's no different from a discogram, which is about 1 to 2% chance of having discitis from annuloplasty or discography. There has always been a theoretical so-called possibility that there is an accelerated disc degeneration. And last but not least, is there a possibility, another theoretical possibility that there's disc herniation from the puncture site from within the annulus itself? So I generally will tell my students that if you have to do annuloplasty, you maximum allow yourself to have 2 attempts. By the second attempt, and you keep attempting it, and you keep poking into that area, you will have greater and greater disc degeneration, and there's an even possibility of a herniation. Some of the important points to help yourself so that you do not get into a problem of unpredictable results. Number 1, select your patients properly. Who are those that are not suitable? Remember we say about very large discs, they are not suitable. We don't want to treat large disc herniation. We want to treat discogenic pain and very mild disc bulge. That's really those patients. Number 2, we want to treat those patients whereby the disc itself is not too degenerated. When they're very hardened, very desiccated, a lot of spondylosis and calcifications, those patients will not do very well with annuloplasty. Sighting of the tip of the needle or as well as the probe itself is very important because the importance is to be able to ablate the painful nerves where it's found in the posterior part of the annulus itself. So it's quite important to so-called site the probe where you want to burn the painful nerves. So you have to picture where you think the painful nerves are, where the pain generator are, and you do that. Last but not least is the possibility of breaking while manipulating the probe. The breakage of the catheter is less likely in flex throat because it's a fairly stiff probe as compared to the IDET, which is highly likely for kinking and breakage. So I will summarize here. With regard to the treatment of chronic back pain relating to a discogenic cause or a disrupted mild protruding disc, there is actually no treatment to be able to say that one is better than the other. So annuloplasty has been, well, in some papers, even nucleoplasty. But for me, I advocate annuloplasty is one method to be able to bridge the non-invasive and the invasive and to be able to achieve good pain outcomes and pain relief for the patients. Thank you.
Thank you very much for a very comprehensive talk. I'm sure on the floor quite a lot of questions will be raised for you. Rất là cảm ơn bài báo cáo rất là hay của ông Bernard Lee. Xin hỏi ở dưới hội trường có ai có câu hỏi gì có thể ta sẽ hỏi luôn trong một vài phút thảo luận.
I have the first question for you. And I did not understand the indication for the annuloplasty. What is the official indication?
So the indication for annuloplasty will be when we find that the back pain is likely to be a discogenic type of pain. That's first. Whereby discogenic pain itself, where there is not very much disc herniation, disc degeneration itself. Alternatively, I will say that mild disc bulges, back pain due to mild disc bulges itself can be also an indication for annuloplasty. I use annuloplasty to treat a painful disc, whereby I feel that the back pain itself is purely due to a painful disc, not necessarily mechanically compressing on the surrounding nerves, whereby there is a mechanical component, but more a discogenic pain generator, whereby there is nociceptor, so-called upregulation in the painful nerves around the posterior annulus.
In case of the radicular pain, do you think that is also a good indication for the annuloplasty? Because by the presentation, there's a lot of hernia.
So the difficulty, see, we can approach it from symptoms or we can approach it from pathology. So from symptoms, back pain plus minus radiculopathy symptoms. So just by symptoms alone, if the back pain, which is purely axial, that is usually the correct symptomology. Because most discogenic pain, they are more purely axial back pain in nature. They are less likely to involve radiculopathy. Although there's about 10 to 20% will involve some amount of radicular pain. Number two is that if you feel that the back pain, axial back pain, and your MRI shows that there is mild disc bulge, mild, not severe, it is also an indication for annuloplasty.
And in case of the Asian pain, do you think that you have to distinguish between the discal pain and the facet pain? It's my topic.
Yes. In fact, it will be an ongoing discussion whether the back pain is coming from the facet, whether the back pain is coming from the disc. It's an ongoing battle. We can talk for hours about this, and there will never be an answer. So we will always say that, is it facet in nature? Is it disc in nature? So I'm proposing that one of the back pain causes is a discogenic pain. Discogenic, whereby the disc itself is the cause of the pain generator. Whereas facet itself is also a pain generator. So in terms of age-wise, I would say that the higher, the older they are, the more likely it's more facetal. the younger they are, 40 to 60, they are more likely to be more discogenic. But as I said, we can keep going on and talk about this, and that's why discogram is a means to prove that the back pain potentially is coming from the disc itself.
And the discogram test is performed when the patient lie down on the table. So how to say that is positive? Because the pain must be in the sitting position.
Very good. So there's always been this criticism about the position in which we apply the test itself. But because in our center we always lie the patient down, we do 3 levels. We do 1 level at the painful disc that we feel that it is the problem. We do another 2 levels that are not related to the so-called pathology. So we do a good disc, a bad disc, and a good disc. And we don't do them in any order that the patient may be able to anticipate. So the patient is blinded to the levels of which is the disc level. And we find whether the patient will report a concordant provocation test. If they say that yes, it is exactly at the level whereby the painful black disc is, then we will say that is a positive provocation discogram.
Dạ. Xin mời chuyển cái mic cho có một đồng nghiệp muốn hỏi hoặc là chia sẻ.
Vâng ạ, chào các thầy ạ. Em xin phép hỏi Dr. Lee một câu là em nhờ các anh dịch giúp em. Cái kinh nghiệm làm cái dose rep của đế đệm của Dr. Lee thì cái so sánh giữa cái hiệu quả của cái phương pháp tạm gọi là cái IDET của ông đang làm với cả cái phương pháp đốt lưỡng cực thì phương pháp nào nó ưu việt hơn? Ở trên cái slide này thì em mới thấy cái bài của ông trình bày chủ yếu về cái IDET thôi. Còn cái vòng sơ mà về cái đốt lưỡng cực, cái bipolar thì cũng chưa thấy ông nói. Cái thứ hai là em muốn hỏi thêm về cái thời gian hiệu quả giảm đau. Cái thời gian của ông đưa lên cũng chưa được dài lắm, thì có những cái ca nào hiệu quả giảm đau dài nhất ở trong bao lâu? Cái thứ ba em muốn hỏi nữa là cái có thể nhờ ông show cái hình, cái thiết bị để đo cái áp lực mà khi ông làm cái discography của ông ấy không? Đấy. Để cái thiết bị mà tích hợp vào cái kim mà khi ông chọc vào cái đĩa để ông đo cái áp lực, cái PSI. Xin hết, cảm ơn các thầy.
Yep, 3 questions for you. And the first one is what's the difference between the bipolar electrodes and IDET?
Okay.
And the second one is...
I'll answer the first one first. So the bipolar, whereby it is two so-called probes.
Annuloplasty.
Yeah, annuloplasty. So you're trying to apply energy from a cathode to an anode, and you try to be able to create a lesion between the two probes. The trouble is that it is a good principle, but it is not very effective. I've tried annuloplasty. I find that the effectiveness is not very reproducible. So I find that the annuloplasty, while it is still being promoted, it has this so-called, it doesn't work the way I want it to work. It's not so reproducible. I want to burn exactly, I want to create a lesion exactly where I feel that the cause of the pain is. When you put the two probes in between and you're hoping something to happen, it is not reproducible.
Cái câu hỏi thứ nhất thì ông nói là cái việc mà đưa hai cái kim lưỡng cực vào thì người ta vẫn bây giờ vẫn đang được đề cao rất là nhiều. Người ta hy vọng rằng là khi cắm hai cái kim đấy thì giữa hai cái điện cực nó sẽ có những cái tác động về mặt điện ấy. Tuy nhiên thì ông cũng không chắc chắn bằng là cái việc là ông sẽ xử lý đúng cái vị trí đau bằng cái kim cái điện cực IDET ấy. Cho nên ông thấy mặc dù là hiện nay người ta vẫn dùng nhiều nhưng ông vẫn tin tưởng là cái IDET nó vẫn tốt hơn. The second one is how long is the longest pain relief lasting?
Yep, sure. I have patients whereby after an annuloplasty, it can actually last for 5 years and more. Yes.
Và ông thấy rằng là đối với trường hợp mà giảm đau như này thường nó kéo dài rất là dài, và nhân dài nhất của ông ấy thì khi người ta kêu đau trở lại có thể đến 5 năm rồi. And the last one is the how to can you share the way to measure the pressures in discography?
Measuring the
Yeah.
pressure, there is actually a device whereby you can actually apply.
What sort of device do you use, and how can you do that?
I suddenly cannot remember the company's name. It just suddenly slipped my mind. But there's a company that actually there is a device whereby we turn and the pressure will actually be monitored. We actually can measure the pressure. It's like a very manometer whereby once it turns, it will actually measure the amount of pressure that is being pushed in. It's the water pressure that's actually being injected into the disc. I'll give you the name of the company later.
Do you often to do inflate anything, or just
No, it's just we apply the injection
Yep.
using the pressure manometer.
Okay.
Yeah.
Yes. Tức là ông ấy bơm thuốc vào trong lúc mà ông bơm thuốc phản quang vào ấy, với mỹ đại thuốc tê thì ông ấy dùng một cái tay bơm, và trên đấy nó đã tích hợp luôn cái đo cái áp lực đĩa đệm. Thank you very much. I think they still have many questions, but we should leave for the end of the session. And please say thank you to Dr. Lee.